evening to all present here, as well as to everybody who has joined us online. I warmly welcome all of you to the second edition of the Dr. Kakarla Subbarao Endowment Lecture. I'd like to begin the program by introducing our Director of Kalamanji Reddy Campus, Dr. Manas Panigrahi. I invite Dr. Panigrahi to give us the welcome address.
Good evening, ladies and gentlemen. So I'd like to welcome you all to the second edition of the Dr. Kakarla Subbarao lecture, and it's a great pleasure to have all of you here as family members as well as our speaker for the day, Dr. Manas. And I'll just talk a little bit about what the institute is today. And it all started with a much younger version of this gentleman who in the early 80s decided to return to India and set up an institute here. And this was what it looked like at that time, and gradually over the years has grown significantly. But this is not what LVP is all about. We also have 4 tertiary centers. We have 4 tertiary centers which are located in Bhubaneswar, Visakhapatnam, Vijayawada, and the most recent baby is at RSR campus at Kadapa. And over the years, we've added several secondary centers. There are 22 of them altogether, along with several vision centers in the remote rural areas. So we are now in over 290 locations across the 4 states. This all came about because of a study that was conducted, the Andhra Pradesh eye disease study, where it was noted that refractive error and cataract were some of the common problems resulting in visual impairment. And this was prevalent in the rural areas, and therefore the need to take eye care to the doorstep of the people. And that's how this pyramidal model evolved, with the vision centers at the base and the center of excellence that's in Hyderabad at the apex of the pyramid, so as to provide appropriate care which was available at the doorstep, which is affordable to everybody and which is accessible to all without compromising on quality. And that's why we kind of married excellence with equity in order to deliver these services. So regardless of a patient's ability to pay, we deliver eye care to everybody regardless of their background. And even if the most complex kind of surgeries would be performed gratis if they couldn't afford it. So over the years, we've developed these 10 functional arms, and while patient care does form the core of our activities, till date we've reached close to 37 million people. There's a lot more to LVP than just that. What's unique to us is the fact that we have a vision rehabilitation center where those who have incurable blindness, the journey for them doesn't end with that. We're able to rehabilitate these people, we're able to empower them, give them jobs, and make their lives more meaningful, and they can contribute back to the society with the work that we do in our rehabilitation centers. And these are across the network. We even have a program that involves community-based rehabilitation out in the vision centers. The education is another forte of ours, where we've reached in the past year itself over close to 5,000 trainees, and we train all cadres of personnel who would be involved in the eye care services, right from the vision technicians and the ophthalmic nursing assistants to the biomedical trainees, the patient care staff. All the staff, all the individuals who are required to help us in our work are trained by us. The other aspect that we've done exceedingly well in an area which was kind of thought to be very difficult to move into is eye banking, and happy to say that we've harvested over 135,000 corneas since inception. As far as transplants are concerned, we're inching very close to the 50,000 mark for this campus, and we've been distributing corneas to the whole country, and that's something that we're very proud of. We have eye banks located in the tertiary centers as well as in the center of excellence. So in research, we've done exceedingly well, and proud to say that we have actually jumped to the number 6 position globally in ophthalmology as far as our research work is concerned. We're number 3 in Asia and number 1 in India. So what's odd about this organization is that we don't just stop with ophthalmology, and we've also got engineers who are on the rolls. So you'll wonder, what are engineers doing in this ecosystem? So they form a big part of the team which helps us to kind of go to the last mile and try to re-engineer products that are expensive, or if the doctors or some of the staff feel that there's something new that can be created, they would work on these areas. And these are some of the devices that have been innovated. Some of them are very, very inexpensive but have a significant impact as far as screening is concerned. Some of them are pretty innovative in terms of the fact that they address areas which have hitherto been unaddressed, and some of them involve software and things like that. So these are some of the devices that we have innovated in our Center for Technology Innovation. But all this, it's for us to kind of reach where we are. It wouldn't have been possible without these 5 values, where patient first. Considering that we have touched the lives of 37 million people, it's important to ensure that the patients remain at the core of whatever we do, and hence whatever we do is towards ensuring that our patients receive the best care possible. We try to achieve the best standards of care, ensuring excellence in whatever we do, as well as equity. And the whole team that you see involved in this brings out the picture of togetherness that we all imbibe, as well as integrity. So without these 5 values in our DNA, I don't think we would have reached anywhere. So with that, I'd like to end and welcome you all to this guest lecture today. Thank you.
Thank you, Dr. Man. Next, I'd like to call upon Dr. Ramesh Kekunia, the Director of Child Sight Institute, to talk about the institution of the Dr. Kakarla Subbarao Endowment Lecture.
Good evening, everyone. Once again, a very warm welcome to this fantastic evening with this Endowment Lecture today. It's my pleasure to introduce Dr. Kakarla Subbarao, on whose name today's Endowment Lecture is happening. Dr. Kakarla Subbarao was an eminent bone radiologist, and he was also a former director of NIMS. Some of you know what is NIMS, Nizam's Institute of Medical Sciences, which is in Hyderabad. After receiving medical education from India in Andhra Pradesh, Vizag, he moved to US. He also cleared American Board of Examinations, and then he was a special fellow in radiology in New York and Baltimore. So he was also faculty of radiology at many institutions in USA between 1970 and 86. Before that, he had a very small stint in Osmania Medical College as assistant professor in radiology, and he went back to US, and then he came back from US, and he's one of the person who is solely responsible for rebuilding NIMS. Today is one of the premier institute in India, and his role is immense in this building of this institute. He is an outstanding radiologist of international repute, and he has many awards and accolades over a 5-year, 50-year career. And one of the most important is he was honored with the Government of India Padma Shri Award. Between NIMS and LVPI, there is always a special relationship. Other than our patients with neuro-ophthalmology, pathology, and neurology, we have an extreme bond which happened right at the beginning of our institute's formation. Our first hospital-based cornea retrieval program started in NIMS. So we have a very long-standing relationship with NIMS. I would like to once again welcome you all to this Endowment Lecture. I just want to tell one quote by Dr. Rao. I passed through this life only once. Let me do maximum good to the largest number of people. This is extremely profound. I think we can get inspired and we can do our best for our patients. Once again, a very warm welcome to all of you for this Endowment Lecture. Thank you.
Thank you, Dr. Kekunia. I now request the head of our Neuro-Ophthalmology Services, Dr. Virender Sachdeva, to introduce our guest, Dr. Manas Panigrahi.
Good evening, one and all. It is an immense pleasure and honor for me to introduce Dr. Manas Panigrahi, who is awardee for today's endowment lecture. Frankly speaking, I think many of us know him and he does not need introduction, but on behalf of Institute, I would take pleasure in introducing him to everyone. He is a consultant neurosurgeon and head Department of Neurosurgery at Krishna Institute of Medical Sciences, Hyderabad. Having done his MCH in neurosurgery from NIMS, Dr. Panigrahi went on to do a fellowship in skull-based surgery in Wayne State University, Detroit. He came back and worked at NIMS Institute, Hyderabad for over 20 years and is currently working at KIMS Institute, Hyderabad, Krishna Institute of Medical Sciences, Hyderabad as the head of Neurosurgery Department. Looking at his repertoire of clinical acumen, you can see all the complex neurosurgical things that we hear of and we refer have all been handled by him. He has done more than 400 aneurysmal surgeries, AV malformations, over 600 pituitary tumors, more than 1000 glioma surgeries, and many cervical and lumbar surgeries. Not only this, he runs a comprehensive epilepsy care program at KIMS and has done more than 750 surgeries for caring for those patients. And to think of debilitating conditions like Parkinsonism, he has been pioneer in treating them with deep brain stimulators. So that is a tremendous achievement. He's an excellent mentor. He has mentored so many postgraduates and MCH candidates. He's an invited speaker for most of the national and international neurosurgery meetings. He has himself organized many CMEs in the field, and he's an avid researcher with more than 140 peer-reviewed publications. He is an achiever since the beginning of his academic career, but he still is very humble, very approachable, and open to collaboration. I think we have been collaborating with him for many years. Even when I was doing fellowship, we always used to refer to him all patients needing a neurosurgery. So without any further ado, we would take the proceeding further, and I would now request Dr. Panigrahi to kindly come on the dais. I request family from Dr. Kakarla Subbarao family, Mr. Jagan Reddy, Dr. Shobha, and everyone to kindly come on the dais. I also request Dr. Garg and Dr. Fernandez to kindly come on dais to felicitate Dr. Panigrahi. We'll now request Dr. Panigrahi to kindly come and deliver the lecture. It's titled Insights into Vision, Exploring the Interplay of Eye, Brain and Neurosurgery.
Good evening. I'd like to thank Dr. Ramesh for considering me for this oration. When he called, I was excited because Professor Kakarla Subbarao has mentored me all throughout at NIMS. He selected me as a faculty at NIMS, and over the period, whenever I never had to go and ask anything. People keep on representing to the EB to start a unit for themselves and all those, but then it came out of the blue for me. He created a unit, gave a unit so that I can do whatever I wanted to do, and so means understanding the need without asking, that is his greatness, and so that's why nobody complained about anything, because everybody got what they wanted, and that's what happens here also. That's why people like to work here. Though my talk is on brain and neurosurgery, like I'll be talking on, I thought because Prasad was a radiologist, I'll speak on how radiology has helped neurosurgeons to give better outcome. And so most of the cases probably would have been referred from LV Prasad only, which the cases I will show. And when we studied anatomy, we knew only imaginary things. We could see the optic nerve, optic tract, but optic radiation we couldn't see. We had to imagine where is the optic radiation. But then with radiology, with diffusion tensor imaging, one can trace the optic tract. One can trace the optic radiation and know the relation of the lesions in relation to the optic pathway. What I've selected is tumors in and around the optic pathway, and what we do to preserve them. Because if you operate and then patient comes with a hemianopia or comes with quadrantenopia, it's useless. So what I'll be discussing is what technology has helped over the past 20 years that we can preserve the visual pathway so that the patient has a better visual outcome. I'll start from behind because all of you do more of anterior parts. I'll go from behind. So I'll take a tumor of optic radiation. Now this is a tumor. This patient came with intractable seizure suspected of a ganglioglioma and in front of the visual cortex. Normally we would have operated from this and damaged the optic radiation, and then patient would have developed hemianopia post-operatively. But now we do an optic tractography and then find the optic radiation. Here we could see that the optic radiation was lateral to the tumor. So we could not. We decided we should not operate through the lateral part, and the only safe area was from below. You can see here now no tracts are below, so we went from below, and then the patient had no post-op deficit. So this is how tractography or advances in radiology helped us to prevent any post-op additional deficits. This is another case. Again, a young girl came with seizures, and this is the striate cortex, and this is the parieto-occipital sulcus, and in front of the lesion. And if we had operated directly, we would have damaged the optic tract. Again, we did a tractography, and then we plan a trajectory using navigation and find a safe trajectory through the parietal lobe, through the interfascicular, and then so that patient does not have any deficit. And to access that, one can use robo, either navigation or robo. What we use robo because we have this, and so here the robo automatically aligns to the planned trajectory, and then we can go through the trajectory and remove the tumor. So this is an animated video of the robo, and this is how it does, and it decides the trajectory, and then we then enlarge the trajectory to remove the tumor. So the process is in a navigation is first, once we place the patient on the table, we have to register and then use the pre-op CT or MR, and then use it for planning the trajectory. So you can see here the robot aligns automatically to the planned trajectory, and intraoperatively you can see whether we are going in the planned trajectory or not and reaching the target. And once you reach the target through the safe trajectory, then we can excise the tumor. So this is what we marked the trajectory, and then make a small flap and remove the tumor. Let me tell an example of geniculate body tumor or a thalamic tumor, pulvinar tumor. This we done yesterday. This is some new technology which we used for the first time yesterday. I thought I'll show it so that people will be excited, because this is something which is we are excited. This is a tumor of the pulvinar of the thalamus, and with the geniculate body just below that. And here we use augmented reality with AI, and so there is a patient sitting on the table with the relatives around. One can superimpose the MRI on the patient and show the patient relatives and patient where exactly the tumor is. We don't need any goggles or glasses, what is used in VR. So we have superimposed the CT scan, what was done, on the patient. And then you can see the blue color is the tumor. the veins are shown, transverse sinus is seen in red color, but that's the color problem. But so we could identify where is the transverse sinus, where is the sagittal sinus, and then where is the tumor, and which will be the safe trajectory. And if you do it pre-operatively, we can mark the flap pre-operatively so that we don't have right-left disorientation. All of us know about Shri and Shri Devi's mother, who had an opposite side surgery in US. If you use this technology, you can mark it on the not in the theater, in the patient's bed, and then patient comes to the theater. So we'll make less mistakes. And here you can see the tumor is here, the vessels are there. We can decide which is the safe trajectory which is the shortest and the safest trajectory without any intervening vessels, so that we can operate. And the same thing we can again do it on the theater. The patient was positioned in the theater in a prone position, and again we use the same thing, same patient, so to mark the flap. So superimposed the 3D modeling what we had done. This technology was actually used. They were promoting only for educating patient, but we thought we'll use it for treatment also. So we marked the flap. You can see here, mark the flap. So we use the pen and shade the area and do surgery. So because when the patient is in prone, many times right left people get mistaken. Normally we keep on checking 2-3 times, but if you mark it before, it becomes easier. And once the marking is done, then we can plan the surgery. The next I'll give an example going forward, a chiasmatic lesion. This is a chiasmatic lesion which means the radiological diagnosis will be chiasmatic hypothalamic glioma. 20 years ago or 10 years ago, people always thought that operating these lesions can have worsening of visual symptoms. They can become blind, so don't operate, give them radiation. But then radiation also had side effect, because most of them are young and they have to live their life, and they developed a lot of cognitive problems, they developed cancers, and they developed cerebrovascular strokes also because of radiation induced. Then came chemotherapy, but then chemotherapy also had their side effects, and then many of them did not respond to chemo and radiation. So what do you do for those patients? You cannot just leave it that no surgery cannot be done. There is a lot of controversy. What is the optimal management? People thought radiation is better. Then they said chemotherapy for younger children, chemotherapy for older children, radiotherapy. Now this is a paper came in 1998, where that was the pre-chemotherapy era. They said radiation is better, but it had a lot of complications, as you can see here: vascular complications, neurocognitive complications, and long-term radiation-induced cancer also. This paper in 2007, that was a chemotherapy era, where the first priority was to give chemotherapy because nobody wanted to touch to do surgery. And always third is only surgery when they do not respond, or it is very big tumor, it has caused hydrocephalus, then only used to go for surgery. But then we did not believe that concept. In 2010, when I was at NIMS, we had analyzed our cases of biopsies which were done of chiasmatic lesions, and what we found is many of them which was reported as chiasmatic glioma were actually craniopharyngitis, tuberculomas, or some other thing. Especially in developing countries, they were they were inflammatory lesions like tuberculoma. So we followed the policy that biopsy has to be done before just empirically sending them for radiation or chemotherapy, and telling them that you have a malignancy or cancer. No, but when we operated, we found, it's not our experience, people who believe in surgery, all of them, the commonest complication is visual worsening, as I told, and 28% of one-third of the patients had worsening of vision following surgery. So we thought, how can we reduce the visual complication? So we started doing diffusion tractography of the chiasm, and then found out whether the lesion has displaced the chiasm or infiltrated. If it's infiltrated, we suggested them directly go for chemo or radiation. But in this case, the chiasm is displaced superiorly. If the chiasm is displaced, then that's a good case for surgery. One can operate without damaging the chiasm. And because many of them are grade 1 gliomas, we don't have to give radiation chemotherapy, so their outcome is better. They have a better quality of life. And in addition to deciding about surgery, we also can decide the approach. Like if this was shifted superiorly, so we did from an inferior approach, frontotemporal craniotomy. But so this was the patient which was operated. This is a post-op scan. This is a child. This is another case where the chiasm, one can see here, it was displaced inferiorly. So if these cases, if you go through the terional, they have worsening of vision. So these cases we started operating from top, from the transcallosal interhemispheric approach, and then we did not have visual loss. So that's how we reduced our visual loss from 30% to almost 5%. So this patient again was operated in 2017 with the interhemispheric approach because the chiasm is pushed inferiorly, the chiasmatic fibers, and it was not infiltrated. And because of most of them are grade 1, we did not give any radiation and chemotherapy. This is another case, same thing we have done with the terional craniotomy because it was pushed superiorly. So when we analyzed cases where DTI was done and DTI was not done, where DTI was not done, we saw that there was deterioration. As I told, 30% of them had deterioration. But when we did a DTI, we had 50% improvement and 50% had same. Their status quo, there is no worsening. So that is how DTI helped us in reducing the complication. So the most important is if the FA value is normal, then they improved. But if it's low, then they were status quo. But if it's infiltrated, we did not operate. And most of them, as you can see in the follow-up, we did not give any adjuvant therapy, no radiation and chemotherapy. Only in few cases where you could not excise, these 2 cases we gave radiation. And that's a significant achievement. And these are some of the child which we had operated. These are not common, so over a years we have very few cases, but it's worth doing it rather than just sending them for radiation and chemotherapy. And this is what we published in 2019, that role the DTI helps in deciding surgery and reducing the complication rate. The next in front is the optic nerve. I'll tell lesions around optic nerve. The commonest lesion around optic nerve is a meningioma, like a suprasellar meningioma, as we got a lot of referrals from this place. And the earlier concept was, if the meningioma is from the left side, means if the visual loss is on the left side, you operate on the left side. But then we analyzed and published in 2002 and 2012, and others also had the same concept that you operate on the side of visual loss. And what was found was, again, there was very few had improvement, and there was still worsening from 0 to almost 20% worsening. And we also had 7.3% worsening, and most of them were status quo, and improvement was only in 27%. So we thought whether we can do something else to reduce to at least have a better visual outcome. So instead of operating on the same side, we had a hypothesis that we operate from the opposite side. If you operate from opposite side, then we do not touch the optic nerve, the optic nerve. So the tumor is removed and the optic nerve is not manipulated, so the visual recovery is better. And this is what is, again, we did DTI to decide. If you do not find the optic nerve in the MR, DTI helps us to know which side the optic nerve and the tract is displaced. Like this patient, you can see here, this is a blue color. The tract is displaced on this side, so we operated on the left side. And also we decide from the coronal MR on which side the attachment is there. Wherever the attachment, we operate from the opposite side, and then we followed up what is the outcome. We divided them, people who had in group A where we had operated ipsilateral, and group B where we had a contralateral approach. Because this was from the department, people still followed the old method of operating on the same side, but we followed from the contralateral side. And what we saw was, whenever we did contralateral side, we had 88% vision improvement compared to ipsilateral, which had 50%. That was a significant change. So compared to our own results that we had 27% improvement, now we have 76% improvement. That's something which is exciting, and we continue to follow. And this was accepted for publication last year. That contralateral approach, when we initially sent, it was rejected 2-3 because people did not believe, but then now they have accepted. The last part of my talk is an optic nerve. Is idiopathic intracranial IIH or hypertension, because many cases come with IIH for referral. We only think of only two things. If there is visual loss, we go for optic nerve fenestration. If there is patient comes with headache, we go for shunt. But then there are a lot of others, means depending on the symptom. The patient has severe headache, go for CSF diversion. Patient has more of visual loss, then go for optic nerve sheath fenestration. But then many patients after CSF diversion, still they do not recover. Many patients after optic nerve sheath fenestration, still they do not recover. And many patients have combination of headache and visual loss. For them, what do? Do you have to do both procedures? 2 surgeries becomes, and when you do optic nerve fenestration, you have to do 1 by 1, and then 2 plus shunt, it becomes 3 surgeries. And shunt also has its own complications. Now there are many options available for IIH. We only practice shunt and optic sheath fenestration, but you have subtemporal decompression, you have dural sinus stenting and bariatric surgery also. Now subtemporal decompression we have forgotten. It was the first method where Dandy in long ago he said that if you do a decompression the brain and open the dura, the CSF gets absorbed by the lymphatics and the ICP will come down. And people forgot about that procedure. And because it's a craniotomy, people are afraid. They think shunt is easy, optic nerve sheath is easy. But this has again come back. I'll be telling example where exactly the craniotomy scores over shunt or optic nerve sheath fenestration. So what we follow is a patient who has diagnosis of IIH. First we give medical therapy. If they fail, we do a temporary lumbar drain. And if the symptoms improve, go for shunt. This is for headache. And if they do not improve with the lumbar drain, then we go for subtemporal decompression with bilateral optic canal decompression. So the indications are failed shunt or failed optic nerve sheath fenestrations. Patient who come with failed I'll show an example of this case for a TP shunt in 2010, and he was followed up. He was okay for 3 years, and again in March, after 4 years he was fine. In 5 years he developed early papilledema, but visual perimetry was normal, so he was followed up. Then after 5 years he started deteriorating and fundus showed gross papilledema, and this patient was treated at Nizam's, and then I think that time optic nerve sheath fenestration was not very popular. People were not doing it thinking that complications are higher. It has become popular now, and we did an MRI. The venogram also was normal. Patient further deteriorated. Lumbar pressure we measured, it was normal. So this is the right case for either optic nerve sheath fenestration. You can see here that the optic sheath is distended in the coronal, either optic nerve sheath fenestration or optic canal decompression. Now we decided to do optic canal decompression because whenever the patient is operated with a shunt, they develop fibrosis and all along the perioptic sheath, and they do not improve with optic nerve sheath fenestration, and the headache also doesn't come down because headache is something is because of the ICP intracranial, and because of the block at the optic canal level. Just draining this takes care of the papilledema but does not take care of the headache. So what we do is we combine optic canal decompression and do a subtemporal decompression. We do a large craniotomy, open the dura, leave the dura open so the CSF gets absorbed in the subgaleal space, so the ICP comes down, and then we do bilateral optic canal decompression simultaneously. Unlike optic sheath where one has to do one by one, here we do bilateral. So this is the optic nerve ipsilateral, the first, and this is the optic nerve contralateral. So we drill the optic canal. All of us know that optic canal is only 1 centimeter, and the thinnest part of the optic canal is the medial part. So doing a contralateral optic canal decompression is easier than the ipsilateral because we are drilling the thinner part. So first we do the contralateral optic canal decompression till we find the orbital fat. You can see here the whole canal till the orbital fat you find, we drill it. At least 180 degrees of decompression, and then open the optic sheath from the falciform ligament till the intraorbital part. So this is cutting the falciform ligament till you find the orbital fat. So this is not done for all cases. For failed TP shunt or a failed optic nerve sheath fenestration, and after shunt if the patient has a normal pressure. So over the past 20 years we have done only 15 cases, but this is quite rewarding for patients whom we tell that nothing can be done. So unilateral craniotomy and bilateral optic canal decompression is a safe procedure and has a good outcome. In conclusion, advancement in radiology and our increased understanding of radiological anatomy has significantly improved patient outcome. Thank you for your attention.
Thank you, Dr. Panigrahi, for that very insightful talk and for showing us novel techniques used in imaging and in neurosurgery. We can take a couple of questions for Dr. Panigrahi.
Dr. Panigrahi, I have one question.
Yeah.
In the augmented reality AI that you showed us, so this is a superimposition of normal anatomy of the sinuses or of the patients that is being shown on the on the skull, like I see.
No, it's of the patient.
Of the patient,
Yeah.
that has been from the CT that we have done.
Yes.
So,
It's not what is taught in anatomy in MBBS. It is customized for each patient.
thank you.
One more question. Because wonderful talk. Have you tried to see the visual fields of these patients if they were done with the DTI imaging superimposed versus now the visual fields, not only the visual fields? And you said that we have compared the visual fields of these patients.
Yes, we have done, because I didn't want to tell about the whole paper. We had recovery of the visual score also. We had to use the German scoring with the visual fields, and we documented that there's a significant recovery in the visual field also.
Thank you.
Can I ask a question? I'm Dr. Manju Bhate. So when you were showing about the optic nerve meningiomas, like we often, and this is basic knowledge, that about avoiding the pile circulation. So that this technique of yours, when you said from the contralateral side you do, I know you showed a supracellular, but would that in any way help preserve the circulation?
Yeah, contralateral only will preserve. Means if you do ipsilateral, then you have to drill the optic canal, you have to mobilize the optic nerve.
Right.
And with that, you can jeopardize the pile circulation.
Right.
So that is why when you do ipsilateral, the chances of visual recovery or visual worsening is high.
Is more high.
So when you do contralateral, you do not touch. So pile circulation is safe.
Right. So wouldn't this be something which people would have tried before? Like, I mean, you said you recently published and they were...
Yeah, there are only
Rejected.
2 or 3 publications.
Right.
People have not published, unfortunately. And actually, this idea came from people who started doing through endoscope from the nose. They said the visual recovery is better when you do through nose because you're working between optic nerves.
Right.
You're not manipulating. But then all the cases cannot be done with an endoscope, especially larger tumors. And meningiomas have a propensity to have satellite nodules 3 to 4 centimeter away from the base of attachment. So when you do with endoscope, you cannot coagulate the satellite nodules. The chance of recurrence is higher.
Right.
So transcranial is better. So we took the idea from endoscope that if endoscopy the recovery is better, then transcranial if you use contralateral it will be better.
Thank you.
Thank you very much. I now invite Dr. Subba to please give the vote of thanks.
I think we had an enlightening lecture. I was listening to your talk, and what I could realize that each research, each thing that you showed us was driven by a clinically relevant problem and how you applied the most important advances in the technology to reach to benefit the patients. So we thank you all of us. Thank you for giving us an enlightening lecture, sir. We also thank the family members of Dr. Kakarla Subbarao Garu for coming us and joining us in person. I thank all the faculty for coming and staying along with the fellows. We also thank our biomedical team, photography team, hospitality team, Mr. Mahavir and Mr. Jacob, who have been coordinating this effort. On behalf of the entire organization, we thank you all once again. Thank you.